Hello everybody and welcome to this pre-recorded BSHAA webinar, part of a trilogy under the Onward Referral Guidance series. One of the most common ways for healthcare practitioners to collaborate is through referral and consultation. Poor communication between referring clinicians and those receiving the referral can lead to disruptions in care, delayed diagnosis, unnecessary testing, iatrogenic complications, and frustrated healthcare providers and patients. Improving the referral consultation process is one of the most effective ways of providing safer care and reducing medical legal cases. This session is titled Recommended Optimal Content for Referral Letters from Audiologists to Specialized Services. My name is Raul Garcia and I am a BSHAA Council member and an audiologist, and I'll be your host today. As you may have noticed, the title explicitly states optimal, as there is no formal consensus amongst the wider healthcare professions as to what constitutes a good referral letter. There are, however, commonalities and themes within all healthcare referrals. The title also begs the question as to whether in an increasingly digital and paperless landscape, the word letter should be accepted in the current and wider context to include other means of communication and not just the physical paper form that we have all learned to associate referrals with. It is outside the scope of this session to dwell into the realms of local, regional, or national data protection regulation, and you are all encouraged to familiarize yourselves with the relevant pertaining recommendations, guidelines, or legislations in your respective areas. An important topic encapsulating the implementation of the General Data Protection Regulation later on this year. Okay, so let me start by echoing what Mr. Bamji, a retired consultant rheumatologist, stated back in October last year in a letter to the BMJ. He said, "There is no such thing as an unnecessary referral." He wrote that letter in response to NHS England's guidance sent to CCGs in May also last year in a document called Elective Care High Impact Intervention, Clinical Peer Review, where it is now being made mandatory that GPs' referrals are peer-reviewed, hoping to make efficiency savings by reducing the number of referrals. Now, private hearing aid dispensers and audiologists aren't GPs, and we often operate in both the private and public settings when considering referrals. In the private world, good quality referrals can improve the interprofessional relationship between various specialties and translate into mutually beneficial arrangements. However, the center of all decision-making has to still evolve around the patient's well-being and benefits. So, in a nutshell, a referral is when you arrange for another clinician to provide a service that falls outside your professional competence. Hence why there isn't an unnecessary referral. If you are unable to provide a particular treatment, service, or product so that the patient's quality of life may improve, refer onwards. The referral process often involves transferring the clinical responsibility from the hearing aid dispenser to another professional. However, a referral is often not a simple mechanical process, but a highly complex interaction that involves multiple stakeholders and that is influenced by a wide range of factors. It is important to recognize that there are various referral types. Sometimes we refer to establish a diagnosis, for treatment, or the consideration of surgical intervention. For a specific test or investigation which cannot be offered in the clinic, for advice on management, for a specialist to take over the clinical management, to reassure yourself, or for a second opinion, to reassure your patient or their family, and for other reasons. It is also necessary to distinguish between elective are routine referrals and emergency ones. Emergency referrals are likely to follow a completely different process to elective ones, and in some cases may be less mechanistic and require different processes in order to accelerate the time from referral to treatment. The following recommendations present headings and content categories, but not specify the precise clinical information required for different clinical areas. To measure referral quality, it therefore seems necessary to focus more on measuring the information quality on referrals than on measuring their structure. The introduction of electronic health records and communication has to some extent eliminated some of the structural problems with referral letters, but further work is needed to elucidate the relationship between the quality of clinical information in referrals and high-quality healthcare processes. This is important as healthcare costs are rising globally and services are being delivered within a framework of increasingly limited resources. In this context, it is imperative to improve patient prioritization based on referrals in order to aid swift diagnosis in those with more serious disease and to provide evidence-based high-quality care to each individual patient. Tools to improve referral quality are paramount. Therefore, following these 7 simple steps prior to making the referral may facilitate you with the process to generate those kind of referrals. Point 1. What is the question I want to answer? Point 2. Who has specialized knowledge and skill to answer it? Point 3. How urgent is the clinical situation? Point 4. Do I need advice from another healthcare provider, or would I transfer the care to another healthcare provider be more appropriate in the specific circumstances? Point 5. Have all the appropriate steps been taken to this point? Point 6. Does the patient understand the reason for the referral? And point 7. Has the patient consented to the referral? It is useful and important to also consider the purpose of the referral from all angles. From the referrer, your angle, because the referral letter forms the basis for establishing the priority of patients for specialized healthcare and for the coordination of care between the services. From the referral's recipient's point of view, so as to facilitate prioritization and planning of treatment and follow-up of the patient. Important to highlight in this section is the fact that often referrals are triaged by non-clinical personnel, and therefore the structure and clarity of the referral is paramount, so the administrative individual is able to ascertain how to action your letter. And obviously from the patient's point of view, in order to ensure that there is a correlation between the information provided to the recipient and that offered to the patient. It is also advisable to provide the patient with a copy of your referral. In terms of the actual content of the referral, it is best to distinguish the 2 key sections, the administrative and the clinical parts, and I will provide you with the relevant key points for both. Let's start with the administrative part of the referral. This is what will enable whomever opens your referral to triage it appropriately. Individuals involved in this process, again, could fall under 2 categories. They would either be clinical, generally junior personnel, or administrative. Either way, they will probably receive lots of different correspondence, and if you are able to ease the triaging process, our referral will be dealt with accordingly. This is particularly true in the larger organizations, irrespective of whether we are referring to primary, secondary, or tertiary level service providers. So we should include the audiologist's name, address, telephone number, email, website, the consultant's name, their department, and the address, the patient's name, address, telephone number, postcode, date of birth, sex, email address, mobile number. NHS number would be ideal if we are referring on to the actual NHS. You really have to make sure that these details are absolutely correct, or it may well delay the processing of this referral. The date of the referral letter, the urgency of that referral, and the patient's preferred communication method, as well as their requirements, i.e. language, sensory impairment, cognitive impairment, and other comorbidities that may exist, i.e. mobility requirements, etc. The clinical part of the referral will depend on who we're referring to, the clinical expertise of the individual making the referral, and the existing facilities within your practice to examine, investigate, and treat the patient or client. But as a general rule of thumb, incorporating the initial sentence stating the reason for the referral, outlining a history or a statement of a problem, important medical history, findings on your examination, findings on investigation with copies of the actual reports, current medications or treatments received, and the socio-psychological matters that are important in seeing these patients, perhaps known allergies. It also aids the referral recipient to better understand the case presented before him or her if the following sections are also addressed in the letter. Whether or how the patient was involved in the referral decision, as it is important to elucidate if the referral emanated from a patient or client's request or whether the clinician or hearing aid dispenser instigated it. What the patient or relative has been told, what presumed diagnosis, if any, has been considered, what the patient or relative expects from the referral, what the audiologist or hearing aid dispenser expects from the referral, and whether it is a new referral or a re-referral. And finally, although not necessarily part of the content of the referral letter, it is always in yours and your client or patient's best interest to instigate an interprofessional reciprocal level of respect by generating good quality referrals capable of, in turn, generating equally good quality replies back to you or the referrer. Therefore, the referral recipient will judge the appropriateness of the referral, whether the referral expectations were met, the general usefulness of the letter, the information about the problem or condition referred, and the audiologist's workup. How well did you present your case before him or her? That's all from me today. I hope you enjoyed the presentation, and do not hesitate to contact the Society should you have any questions for me. Goodbye.